Hey everyone, Tony Ambler-Wright here, joined by my fellow master instructor, Ken Miller, and welcome to our second installment in the Return to Performance series. In this episode, we're going to focus primarily on the foot and ankle complex. So really excited to get into some of these specific areas of the body that we can work on reconditioning. Last week, if you were able to listen to the first installment in the series, we provided an overview of, what is return to performance and discussed some of the things that should be considered as you're assisting clients and or athletes through the reconditioning process. First, let's start off by discussing what we're going to cover today. First thing we'll do is we'll get into some of the specific foot and ankle lower leg injuries that you might encounter or that your clients might experience and that you're going to help them fully recover from. It should be addressed that, what we're going to focus on primarily in these episodes is beyond the acute rehab stage. So remember, we talked about a multidisciplinary team in our last episode. Where you've got the medical providers, you've got the rehab professionals, and then what we're going to be talking about is kind of that bridge between rehab and the return to full performance. So much of what we're going to discuss today as it relates to the programming and the strategies that you would implement with your clients are going to be from that perspective. We'll also talk about, what does full recovery mean? What is the goal? And then, what can be done, most importantly, what can be done from a self-care or trainer or coach directed standpoint? And what are some of the things that you can do prior to full integration into practice, strength and conditioning, and competition? So again, super excited to be here. Ken, glad to get on the line with you again and excited to go over this topic with you.
Yeah, I mean, that's, I look, if there's going to be one highlight of my week outside of family, this is going to be it, so always great
thanks, buddy.
Communicating with you, man. Especially from the standpoint that, again, if you haven't listened to what we did last week, so highly encourage is watch the video. Watch the video, and you'll get an idea of where we're coming from just a overall, I guess, an approach. So let's, so the thing about it is that we're talking about getting somebody back into the playing field. And again, Tony, just to get back to it, you've got a lot of great experience, and I know that offline we've shared some stories, but I'm really looking forward to hearing what you've done with your athletes to get them back on the field, because you read about these players and tell me what you think about this, Tony, but you're watching ESPN or some kind of news report, and this guy's going to be out for 3 weeks, 4 weeks, and then a week and a half, 2 weeks later they're back on the field, right? So Obviously something was done to get them to where they can actually not just get, walking normal, whatever that means, but also to the point where they can compete again, to actually be competitive and be a presence on the field. So that's what I'm looking forward to gleaning from this conversation today, especially when we talk about the foot and ankle and the injuries that typically come with that region, and especially since, and we'll talk about ankle sprains in a little bit, but ankle sprains being, the biggest injury across all sports, right? So looking at
sure.
the preventative side, but also if it happens, and statistically, if you compete in something, it will happen. What can we do to address it moving forward?
Yeah. And selfishly, likewise, I'm looking forward to hearing your stories as well, and glean some stuff from your experiences. So should be fun.
Yeah.
All right. So, yeah, I guess also to those watching, if you do have any questions, please feel free to leave them in the comment section. And what we'll try and do is, if we can't get to them in real time, then we'll address them in subsequent episodes. So, please, by all means, we want to make sure we address any questions or elaborate on anything that we cover as much as we can. So feel free to leave those in the comment section below. All right. So first, let's talk about some common injuries to the foot and ankle complex and or the lower leg. Basically, we're talking about from the knee down. And Ken mentioned this, but the most common lower extremity injury in the athletic population is going to be an ankle sprain. And I guess because we have a wide array of professionals that are probably listening, just want to make sure that everyone's aware of the difference between a sprain and a strain. A sprain is going to refer to an injury or an overload to a ligament, whereas a strain is going to focus on muscle tissue or injuries to musculotendinous tissue. Ligaments, relatively inelastic tissues. Their primary job is to provide support and stability to the joints. They also control the position of the bones during joint movement, and they provide a high degree of proprioceptive input or joint position sense to the central nervous system. So ligaments are rich in receptors, and they provide information related to the position of the joint, and then the body can react and respond appropriately based on that feedback. The most common ankle sprain is going to be what we refer to as a lateral ankle sprain. So it's going to be, an injury to the lateral ligaments of the ankle. Most common injury by far and most prevalent in field and court based sports. The lateral ligament that's often most injured is the ATFL or anterior tibial fibular ligament. It's the weakest of the ligaments, lateral ligaments, and therefore it's injured with the greatest prevalence. Some other things you have to consider with a lateral ankle sprain are, potential bruising to the talus, which may prolong some of the recovery time associated with an ankle sprain. And then I think as it relates to what we're talking about in reconditioning and returning an athlete or a client to full performance is the longer term effects of, sorry guys, my screensaver came on, threw me off. One of the biggest things that we have to consider when it comes to the long-term effects of an ankle sprain is what we refer to as chronic ankle instability. So you'll often see the acronym CAI. Chronic ankle instability occurs in anywhere from 25 to 50% of the population when you look at general population as well as specific athletes. For example, dancers, if they sprain their ankles, a higher percentage of dancers who suffer ankle sprains are going to suffer from chronic ankle instability. That's on the upper end, about 50%. And then general population might be closer to 40%. And then certain other athletes may be on the lower end of the spectrum, around the 25%. So that's something that you have to think about when you're developing a program to get a client or an athlete fully backed and reconditioned, is that chronic ankle instability, which will increase the susceptibility of a repeat or recurrent ankle sprain. Let's see, the a lateral ankle sprain, is often referred to as an inversion sprain. And then, less common ankle sprain is going to be your medial ankle sprain, which is often referred to as an eversion sprain. And then the final thing that you might hear about, or final type that you might hear about, is a high ankle sprain, which is also referred to as a syndesmotic sprain. And really, that's an injury to the interosseous ligaments between the tibia and the fibula. Usually, it requires a longer recovery time, and therefore may require a little longer immobilization. and your athlete or client may have greater difficulty with weight bearing or returning to weight bearing with a high ankle sprain. But regardless of the type of sprain, over time, as you start to recondition the client or the athlete, the approach that you would use is going to be very similar. And that's a good thing. As we get into some of these other conditions or injuries in the foot and ankle, the same could be said for those too. Is that the approach that you'll use, the things that you're looking for from a range of motion, strength, and control perspective are all going to be very similar. And that's why we're kind of lumping all these things into one session here.
Right.
Ken, do you have any insights from your time? Obviously, your extensive time in collegiate athletics with a wide variety of athletes. I'm sure you saw this quite a lot. Anything you want to add?
Yeah. I mean, the only thing that I'll add onto this is that, well, to put it in context again, to get somebody back from injury into competition or participation, we'll say, is that, for these various types of injuries that you've lifted off, Tony, is that if the person has gone through, let's say, the typical, sports medicine route and then transitioning back into strength conditioning, all of these things will have been brought to your attention. And if it's somebody that's, let's say, a high school athlete, they maybe went to an athletic trainer, maybe saw their primary care physician, and they've diagnosed it. So, these are terms that you'll see in a sheet of paper that usually be brought to your attention by the time it comes to you having to address it with your programming. So it does help. So if I know that, if we've got, this high ankle sprain, we know we've got something that's, that needs a little bit different attention as far as the time it's going to take for somebody to come back. And again, that's all going to be individualized anyway. So I guess the big thought here is that, the more information that you have as a fitness professional or strength conditioning coach, the better decisions you can make when it comes to creating a program. But again, going back into last week's session, we are talking about, staying in your lane, scope of practice. If I know that somebody has gone through the medical side of their rehabilitation process, I'll have my do's and don'ts, and then I can create my program there. So I know we're going to get into the assessments that we might use in the field, but as far as these injuries go, I'll let the athletic trainer or their physical therapist or their doctor tell me, okay, what's the condition? Yeah, did their ankle turn nice, pretty colors? And how is that part, of the process coming along before, we can move things along? There's physical therapists that say, okay, got a little bit of swelling, still have some discoloration, but we definitely need to get that ankle moving for them to still participate. If we're looking at them participating for practice in a couple of weeks to try things out. So as far as, the different sports go, whether it's, I definitely saw a lot with, gymnasts that I've worked with, but, you'll have your typical soccer, football, definitely quite a bit there because you have both contact, non-contact, basketball, which is why I don't play basketball. Not because I'm 5'8", but I sprain my ankle. I sprain my ankle a lot, but from that vantage point, once you know what you can and cannot do, then you can move on to your assessments that you use to help you make a decision on what should be done, and then program design based on what they can do without pain or discomfort. Because again, that pain and discomfort, that's usually outside of our scope, but we can use that information to help us decide what's working and what's not.
Yeah, or if you need to refer back out to the medical side,
right,
for sure. And the other interesting thing too about ankle sprains is they're typically a non-time loss injury, and that could be due to it maybe not being that serious, or because maybe people the rehab or the reconditioning approach might be accelerated And, the recurrence of ankle sprain is typically pretty common.
Right.
So I'm wondering if if it's viewed maybe as a less significant injury than it maybe is in some instances. So cool. No, that's awesome insight. And I'd have to play it back. I can't recall, but I think I might have misspoken when I referred to the ATFL ligament. It's the anterior talofibular ligament. So it attaches the talus to the fibula. I think I might have said tibiofibular ligament, which obviously is the tib fib joint, distal tib fib joint down at the ankle. So apologize, can't play it back right now, so I don't know if that's what I said or not. But ATFL, anterior talofibular ligament.
Well, I was gonna call you out on that later on, Tony.
Yeah, you're gonna be like, Tony, what are you doing, man? But yeah, ATFL, most commonly injured ligament there. All right, so that covers sprains, common, very, very common. And sorry, gang, my screensaver. I need to reset or adjust the settings on this thing.
Turn that off, Tony.
Next, we can talk about tendinopathies. Tendinopathies typically, they're caused by overuse. We'll talk about a couple things related to tendinopathy. Typically, you might hear of Achilles tendinopathy, also plantar fasciitis, fasciosis. Might be able to lump those kind of into the same category. Just so we're clear, if you hear the term tendinitis or fasciitis, itis refers to acute inflammation of the tissue. So in the case of tendinitis, it's going to be acute inflammation of the tendon versus tendinosis. When you hear osis, that's going to be referring to more of a chronic condition where there's micro tearing and a degeneration of the tissue over time. And how those are approached from a rehab, reconditioning perspective are going to be a little bit different because you're dealing with two different and two distinct things. So tendinopathy could refer to either of those scenarios, tendinitis or tendinosis. So Achilles, plantar fascia, again, we'll talk more about this when it comes to programming, but a lot of the issues seen there can be tied back to overuse, maybe too much volume, or too much intensity too soon, or too frequently with not enough recovery time. And then from a kind of a movement and kinetic chain perspective, when we look at factors that would influence those things, often we're dealing with an inability to control eccentric forces in the lower extremities. So as you perform dynamic activities, running, jumping, cutting, et cetera, it's an inability to control lower extremity pronation can really be tied back to a number of these things that we're talking about. And so in the case of the Achilles, if there's a limitation in dorsiflexion range of motion, that's going to create compensations through the lower extremity and into the foot and ankle, which could overload the Achilles. If there's a lack of proximal hip control, hip strength, proximal stability, the athlete might be relying more on the lower extremity and the muscles and tissues in the lower body down near the foot and ankle and lower leg to control either control forces during deceleration or produce forces during acceleration. And then in the case of plantar fasciitis and issues with the plantar fascia, typically it's caused by an overstretching of that tissue, as seen in somebody that overpronates or lacks the ability to control excessive pronation during functional activities and tasks. So, Ken, anything you want to add there?
No, that was actually really thorough. I was like, okay, I can talk about it, and then you continue talking about it. Just from especially with the plantar fascia, a lot of things going on with the bottom of the foot, especially when we just passed the New Year's resolution crowd, And, with a lot of people trying to find a treadmill, trying to get, onto a Stairmaster or something like that, and that's where I typically get a lot of just general population coming in and talking about, what's happening with their foot and ankle, as far as, the bottom of their feet, get sore. They have trouble walking, things like that. But also just, when you talk about race season, I know that, due to current situations, races being canceled, I'm not seeing that, but that's another thing. As local half marathons and marathons start popping up, in where I live, San Francisco, Oakland, as you get closer to race time, that's when you'll start to hear the complaints, as far as the pain and discomfort and things that they feel as they definitely escalate the amount of volume in their training. And, it's just either, it's just too much too fast generally when these things start to pop up. But, as we get into program design, we'll talk more about how to resolve those issues.
Yeah, for sure. I know I'm guilty of that a time or two, committing to a race, half marathon, 10K, not really doing what needs to be done from a preparation and training standpoint, and just jumping right in there. Certainly feel the effects of that afterwards.
Get off the couch, get off the couch and run.
That's right. Couch to 5K, couch to half marathon. Cool. Let's see some other stuff you might encounter. Muscle strains. So we talked about sprains, which are more, which have to do with the ligaments, and strains are referring to muscle tissue. Strains can occur anywhere along the muscle tissue, whether it's in the muscle belly, the musculotendinous junction, or where the tendon attaches to the bone. Common one here in the lower extremity is going to be a calf strain. Calf strain, majority of calf strains occur in the medial gastroc at the muscle tendon junction. And again, if we kind of think about this, we'll refer back to this quite a bit, and we'll definitely address this in the programming. But if you think about the mechanism behind a muscle strain, typically a muscle strain is going to be caused by the tissue getting forced to stretch too much. So it gets overstretched and it can't control that, or it's being asked to exert force against too much resistance. And so when we think about the medial gastroc as a particular example, if you're dealing with an individual who has a hard time controlling excessive lower extremity pronation, that medial gastroc is going to be eccentrically overloaded quite a bit as a result of that, and that's going to increase increased eccentric stress may increase the susceptibility to tearing. So calf strain, and then let's see another common one. Speaking of runners, and ramping things up too soon might be quote unquote shin splints. You've got your anterior shin splints, and you also have your medial shin splints. Medial tibial stress syndrome is kind of the clinical term for that. Again, that's another overuse type scenario where you're going from relatively little to no training and activity to too much or too intense without enough recovery. And with respect to medial tibial stress syndrome, often it's the result of eccentric overload to the soleus and or the posterior tib as they work to decelerate lower extremity pronation during functional movements. So if we use running as an example, as those muscles control eversion of the foot during foot strike, if there's overpronation or excessive pronation occurring rapidly, it's going to increase that eccentric stress to the tissue, and that's going to lead to the inflammation, pain, and micro trauma to those areas. So very, very common. But again, if you notice a theme here, a lot of this is related to the inability to control and decelerate forces eccentrically during activity. So when it comes time to what you can do about this to help your clients recondition and return to performance, that's going to be a key theme here.
Right. And the one thing I do want to add here, in the context of this webinar is, the foot and ankle, but, one of the things that we can't forget, or if we don't understand it now, a concept that we need to understand is the regional interdependence model, and that a lot of these dysfunctions just closely related to what's happening at, right above it at the hip too. So when we talk about, when it comes to, heel strike or how our foot interacts with the ground, a lot of that's going to be dependent upon how the hip is moving that leg into that next step or next stride. So, if it's about foot placement, we talk about eversion, things like that. But, again, something to also consider when we're talking about foot and ankle issues is that, we have to take consideration, probably equal amount of consideration as well, to the hip, even though the foot and ankle is what's experiencing the injury. The hip is one area that we also need to look at, but we'll discuss that at another webinar.
No, absolutely. No,
Yeah.
and thanks for bringing that up and reiterating that. I think you'll see when we get into some of the specific strategies that the hip is going to be involved. Because when it comes to decelerating force in the lower body, the glutes are a key component of that. And if the lumbopelvic hip complex, if there isn't good stability, if there are range of motion deficits that are affecting mechanics there, then that's going to transfer down to the foot, to the knee, and to the foot and ankle. So, no, great point. And really, the approach that we're going to take with all these scenarios that we cover over the next number of weeks is, this regional interdependence or kinetic chain approach, where you can't just focus on the site of injury, which, may be a consideration for the acute rehab phase, but as our roles and responsibilities translate into returning to performance, we have to look at the body as an integrated unit and how everything is working together to help that individual perform optimally. So great points, Ken. Glad you brought that up. So let's see, going back to our agenda and our topic points, I guess, your client sustained a particular injury. They've gone through the acute rehab phase. They're ready to start progressing back into full performance and activities. I guess we have to answer the question, what does full recovery mean? And that will certainly dictate the plan of action that's created. Full recovery for a general population client is going to be significantly different than full recovery for a collegiate athlete or a professional athlete in some regards. Maybe not in terms of what they want to accomplish entirely, but maybe the timeline needed to get them there is going to be different. So, generally speaking, full recovery, often means restoring full range of motion, stability, strength, power, neuromuscular control, and efficiency. Also conditioning and endurance during sport and activity specific skills. So, but that's where it'll be important too to talk to the athlete, talk to the client. What is their definition of full recovery mean? Maybe that differs from what a coach or another individual on the team. Maybe that's different than their perspective or their thoughts about what full recovery means.
Exactly. And this is where, again, having that little roundtable discussion and, having the medical professionals involved in the conversation, the coach, but also the athlete. It's one of those things where, you have all these conversations about somebody, but not with somebody, so understanding, where the athlete needs to be. Cause I've seen plenty of, I guess more than a few athletes that, we've discussed, with the head coach, with the athletic trainer, and then myself, we're talking and talking and talking about them. But, and we've gone through the protocols, and, 3-4 weeks go by, and we're hitting all our objectives and sticking to the plan. But then, we, failed, I guess, from that standpoint, to actually talk with the athlete and what that means to them. Like, okay, yeah, I can play. I'm participating. I'm still on the roster, but it still hurts me when I do this. So there, and it has nothing to do with the sport. I can run, I can jump, I can change direction, but when I sit down for my class for more than 30 minutes, I get this sore tenderness in the front of my hip. So these are the things that, have to be a part of the discussion. So again, it's easy to talk about the sport, but it's also just as easy to lose the person that's in the middle of the conversation. So again, to your point, full recovery from a physical, psychosocial perspective, they have to be included in the process as well. So like I said, they can hit all the markers, but if there's something that hasn't been considered, then it may not be seen as a success by the main person that needs to consider it a success, and that's the athlete, or the participant in that sport.
Yeah, no doubt. And that goes back to what we were talking about offline regarding the confidence of the client and the athlete. Again, when it comes to functional testing and their ability to, perform certain things, they're hitting all their benchmarks and where they need to be. But if they lack the confidence in themselves to be able to perform on the court, on the field, or there's some apprehension there because of fear of re-injury, then that isn't really a full recovery in my book, and probably wouldn't be considered full recovery in theirs either. So that's equally, if not most important, outside of the physical attributes, but psychologically, where are they at, and are they ready in that sense?
Yeah, exactly.
So, cool. Well, I think now let's get into, what can you do from a reconditioning and return to performance standpoint? What are some things that can be done from a self-care perspective? So if you give the athlete or the client has to be a part of this process. We just talked about they need to take some responsibility for their return to activity. And then, what are some things that you can do as the trainer or the coach? And then, again, we're kind of talking about that bridge between, full integration and into practice, strength and conditioning, and competitive activities. As we go through some of these things, we might highlight a few things relative to some of the injuries that we discussed earlier. But again, when it comes to this process, we're really looking at it from a kinetic chain perspective, regional interdependence perspective. And the goal should be to establish or reestablish dynamic neuromuscular control and neuromuscular efficiency. So in the competitive environment, performing the activities that they want to return to, what does their control look like at speed, multiple planes of motion, under similar demands that they'll encounter when they're performing their sport or activity? And neuromuscular efficiency, that term's thrown around a lot in the NASM materials, but that's essentially just ensuring that all the right muscles are working together to be able to control, dynamically control eccentric forces on the body in all planes of motion, stabilize against those, which then provides a solid platform to be able to produce force concentrically and accelerate forces. So is everything working as it should? Are they able to maintain proper alignment? Are all the right muscles firing in the right sequence with the right amount of force in order to accomplish the task without compensation? And that's the goal, is to get them there.
Right. And neuromuscular efficiency, it's just a fancy word for coordination, right? And can they control their body? One of the things that I learned early on when it came to working with teams and in the strength conditioning field is the fact that the other assistant strength coach, David Zimba, told me, and the words just pop in my head anytime I work with an athlete. It's like, if you can't control your body, you cannot control your opponent. So if you can't control and command what you have, which is your own physical body, then how do you expect to impose your will on somebody else? Right. So if you're playing a lot of contact in soccer, well, if I'm a little floppy and loosey goosey around the spine and the hips, and not to mention the ankles, then how can I expect to be able to push somebody or even hold my space against somebody else? Right. So when we talk about neuromuscular efficiency, coordination, am I coordinated enough, like you're saying, Tony, to not just produce force, that's just accelerate into a given direction, whatever that direction may be, but can I stop? Can I decelerate? Can I hold a spot? Especially when this force vector is coming at me, can I hold my position? Again, I can't predict what direction somebody's going to come at me or how hard they're going to hit me, but what I can control is, okay, what can I do to train my ability to hold my place in space? So there's the ability to produce as well as reduce force. And I think when it comes to return to performance, it's the ability to stop, whether it's to stop your body or to stop somebody else's body and hold your place in space. So that's the number one thing when it comes to coordination that I think a lot of us never learn, or if we've learned it, we don't apply it. So when it comes to that whole, can I coordinate my systems, my joints? Can I get everything synced up? Synced up for what is the question, right? So again, when it comes to this reconditioning and returning back to competitive performance, I think one of the things you have to keep on the forefront of your mind when putting programs together is, okay, can this person just coordinate themselves and then coordinate it for a purpose?
Yeah, for sure. I love it. That was such a profound statement and makes complete sense. And, it's interesting because when you look at, since we're talking specifically about the foot and ankle, when you look at some of the, when you look at some of the progressions from an exercise standpoint, proprioceptive exercise is used quite a bit in foot and ankle rehab, standing on unstable surfaces and re-engaging those receptors around the foot and ankle to be able to control the lower extremity. But you bring up a great point. In many sports, you also have to contend with contact in the upper body, right? So if you have to contend with forces and somebody's coming at you, that's going to create a different set of demands that you have to be able to control at the foot and ankle. So when it comes to your instability training, proprioceptive training, directing that stimulus through not just the foot and ankle, but through the other parts of the body is going to be really, really critical to that process.
Right. So, and just as an example, I know we'll get into this, but even things like, with that proprioceptive demand, I mean, just simply rotating your body, right? That's going to create a different proprioceptive input when it comes to how the foot and ankle are going to react. Now, even just the slight difference of having a lacrosse stick, right? So if my hands have to be in a certain position to have both hands on the lacrosse stick, right, at a certain angle, if I'm running, typically, it's going to be up and over to the side. I have to be able to run with my arms in a specific position, right, as my foot and ankle are doing different things. So again, as we get into the programming side of things, I want to see that, okay, if their hands have to be in a certain position, is this a new and novel or a foreign position for the foot and ankle to experience with the upper body to be shifted and turned this way? Right. So whether that's rotated right with right hand above left or rotated left with left hand above right, those are all variations in the programming that, again, if I'm looking at a single leg squat, maybe I do a single leg squat, still hips level, shoulders level, but my hands are slightly repositioned, again, just to reacquaint my foot and ankle to be in a position of challenge with that slight variation of, what's happening above it.
Yeah, changing that center of mass, center of gravity. That's awesome. For the listeners, could you go through just an example? Let's say using a right-handed athlete, lacrosse, let's say a lacrosse athlete. What are some things that they would have to control? I guess it would be on the left side. So what would you typically see if somebody's reaching? If they're reaching overhead and to the right while they're standing on their left leg, what are the things that you would be looking for? You would be trying to challenge in that sense.
Well, some of the things I'd look for, just again, without any kind of contact, without any external force or perturbation. Again, that's just something as simple as just tapping, just offsetting or just stimulating the nervous system from that standpoint. It's just can they control? So if they're rotated. Again, can they disassociate? Can they just turn that upper spine, or do they have to take the hips with them? Right. So it's not uncommon. Somebody that's a little tight, facilitated, they haven't been able to disassociate their hip, have that left foot or left hip externally rotated while the hip is opening up to change direction. Can they turn? Can they let one joint do one thing while the rest of the body does something else, right? Or do they have to take something along for that motion to happen? So if they turn and then that left knee, if they turn to the right or further to the right, does that left knee collapse in? Does that foot collapse in? Are they strong enough? Do they have enough stability and integrity through that left hip and foot and ankle to let that foot stay open, let that knee, hang out between the hip and the foot and ankle, right? And a lot of times we can point at the groin for that, or if the foot and ankle are, unstable, and you have that, like you mentioned earlier, that overpronation, and then you have that knee valgus to come along with it. And you think for as many reps as they're going to do that knee is collapsing in, the foot's collapsing in, a lot of times excessively and for too long. So what I'm looking for is can they disassociate one segment of their body from the other? At the same time, can they coordinate it? I guess that's a version of coordination, right? Can they do a particular task while having the stability and the strength of a respective joint speak for itself? Does that answer your question? So I'm looking at
that's awesome.
So with the kinetic chain alignment.
I'm sorry, go ahead.
I was just going to say with kinetic chain alignment, that's what I'm looking at, just generally ears, shoulders, hips, knees, and ankles. And do they show the compensations that we might look for in other assessments, like excessive low back arch, too much, shifting of the lateral shift, right or left, hip drop, forward lean. Can this guy run and not, or even pass the lacrosse ball without, excessive compensations as they might exhibit themselves? Again, sports is sports. There's going to be things you're going to have to do to the body, or the body's going to have to take different shapes and forms during performance compared to what's in a controlled environment, where there's nothing around you and I'm instructing you and telling you what to do. So I leave the sports activities to the coaches. I'm not a sports coach for any kind of sport, but from just a physical command standpoint, that's what I'm watching out for. So if they're doing this, if they're rotating, but they have to arch their back to do it, I'm going to help them get better control of what's giving them that compensatory movement pattern.
Yeah, yeah, for sure. No, that was great. Yeah, I think part of my goal with that question was just to get the listener to realize that as you reach to the right while on the left leg, that you're going to have to control those lower extremity pronation forces, and that's rotating in that way is going to create some obligatory movement through that lower extremity, and that you have to take that into consideration when you're programming your exercises, but also when you're monitoring your client's form and technique. You're giving them cues as well as reassessing. So that was great. Again, just generally, we talked about kinetic chain approach, but you do have to focus while looking at the whole body is important. You do still have to make sure that things are from an isolated standpoint around the area that was injured, that you've restored isolated range of motion, strength, endurance, power to those tissues before or while you're reintegrating all of that into a total body, functional pattern or activity. Some of the things that we'll talk about are more, corrective exercise focused, where, maybe more therapeutic, a little bit lower on the intensity scale, and then, progressing into, more conditioning oriented activities that might more closely replicate what they have to do from a sport or activity perspective.
Right.
So, all right, cool. So foot and ankle. Oh, go ahead. Yep.
I was going to say, I do want to say that, when we talk about corrective exercise, and I'll be the first to admit I've lost more clients than anything else when you start talking about corrective exercise.
Yeah.
Because, if I have a golfer, if I have a 65-year-old golfer, one comes to mind, it's like, I just want to play, right? I don't want to lay on the ground, and I don't want to do these 15 slow, monotonous repetitions, even though they feel better. They'll admit though they feel better, but the aspect of corrective exercise and performance, this is where, again, you and I, Tony, talked about this earlier, is that, we have to get them to understand that this is the threshold you've got to walk through as far as getting back to sport, not just to play in sport, but to help you become the resilient athlete that you should be. Because for us to not go down this road again, you have to be stronger than where you were before you got hurt, right? So and it's because they don't like to do slow, monotonous, perceived as slow and monotonous work. They don't want to sit in the ground. They don't want to go inside someone's four walls. They just want to be out in the field. So when it comes to the corrective exercise, I think when it comes to fitness professionals, we just have to communicate that, okay, this isn't the end all be all. This is just something we have to do to help build stability, because strength is founded on stability. And then for what you do for your sport, let's pick golf, which is a power sport, and power is built on strength. So you're only as strong as you are stable, and you're only as powerful as you are strong. So when it comes to the corrective exercise aspect, this is where, again, getting back to communication, we have to be able to reiterate that, okay, this is something we're going to have to revisit, but we have to be here now to get us to that next level.
Yeah, no doubt. Hugely important. Yeah, you've got to make sure that you're speaking in terms that are relevant to the person in front of you, so that they understand, you're aware and understand what their goals and aspirations are, and you're doing what needs to be done to get them there.
Right.
So when it comes to great points, when it comes to considerations for programming, as you begin working with somebody, there may be some swelling and inflammation as a result of increased activity. So you want to, be aware of that. There are plenty of strategies that you can implement to deal with that. But if it gets to a point where, there's some pain and soreness, some continued swelling and inflammation, then, you may have to rely on the other professionals in your network or as part of the team to address those things because they're not within our scope. We talked about this earlier, range of motion. Ankle dorsiflexion is one that you really want to focus on with the majority of these lower extremity injuries to the foot and ankle. A lack of ankle dorsiflexion is going to contribute to that inability to control pronation and may lead to excessive or prolonged pronation during functional activities. So restoring ankle dorsiflexion is going to be key. We can't neglect plantar flexion, so you can certainly address that and check that. And then when it comes to some of the other motions, ankle inversion, ankle eversion. So making sure that you've restored that. And then another one is knee extension. So even though it's a measurement that you would do at the knee to assess hamstring extensibility, the lateral hamstring attaches to the proximal aspect of the fibula, and that fibula articulates with the distal tibia to form the tibiofibular joint. So what's going on proximally at the tibiofemoral, at the proximal tib-fib joint is going to have a direct impact on the distal tib-fib joint or the ankle. So as you dorsiflex, as the foot moves and accepts forces eccentrically, there has to be certain motions that occur at that distal aspect of the tib-fib joint. And if there's tightness or limitations in extensibility of that lateral hamstring that's pulling on the fibula, that's going to affect the kinematics of the ankle joint secondary to that. So we want to look at knee extension and make sure that that's where it needs to be. And then from an isolated strength and stability standpoint, those local muscles around the foot and ankle everters, inverters, dorsiflexors, the anterior tib, plantar flexors, tibial rotators. So again, if we're looking at the regional interdependence approach, we want to make sure that, again, if somebody is unable to control pronation in the lower extremity, that's going to involve external rotation and abduction of the tibia typically. So you need to make sure that the tibial internal rotators are strong and active and able to control that. We also have to look at the glutes, both in an open chain and closed chain. Can they control the lower extremity? And then the proximal core, is there stability there to be able to allow the lower extremity a solid foundation to work from and control forces from? So foot intrinsics, can't remember if I said that or not, but the foot core, if you will, you want to make sure those guys are where they need to be. Some other considerations too, just as it relates to overpronation and the ankle sprain. Typically, when an athlete experiences an inversion sprain, since those are the most common sprains and one of the most common athletic injuries, you might see the cuboid be affected. So as the ankle gets inverted, the peroneus longus is going to rapidly contract to try to control that, and that can cause displacement of the cuboid, which is going to that can create pain and discomfort on the bottom of the foot, but it can also contribute to eversion of the midfoot. And so when you're looking at restoring foot and ankle function, you have to be aware of some of those things from a joint kinematics perspective. The calcaneo cuboid joint, the tibiofibular joint, both proximally and distally. Also the position of the talus. So when you get when you get a lateral ankle sprain, the talus can be displaced anteriorly. And, if you're doing things from a muscular standpoint, stretching, foam rolling, and you restore range of motion, there still may be some positional faults at some of those joints. So that's where the medical professional or the rehab professional can perform mobilizations and certain techniques to restore normal kinematics there to the joints, which is going to immediately impact how that foot and ankle functions during exercise and during activity. So just some other things to consider, even though you're focusing on muscle strength and range of motion and kinetic control and alignment, there may be some isolated things down at the foot and ankle that you want to make sure you hit up to if you're not getting the outcomes that you expect.
Right. And that's the other thing. I mean, well, getting as far as looking at your markers and the desired outcomes and whatever projected timeframes, again, there's a lot of anatomy that you just spurted out there, Tony. But for one, that goes into the idea that, again, if you're a fitness professional and somebody's come to you because they want to get better at a sport or they want to return to a sport, injury is part of their history or not, or maybe their assessments tell you that, they're just, you don't want to say that, okay, you're at a high risk of injury, because we're not in a place to say that. We just know that when there's compensation patterns that have been exhibited, know that you're putting certain stresses on joints or you're not using your muscles as efficiently as they could, which again affects acceleration, deceleration, stabilization. But, what really is the foundation for all of that is understanding your human anatomy. And Tony's one of the best guys that I know as far as understanding functional anatomy, as far as the interconnected function of how muscles, as you were just mentioning, Tony, with the lateral hamstring, how it connects to the proximal fibular head, which again connects down into the ankle. So first, that's a big point that I gleaned from your explanation of how the joints are working together. But again, whatever the markers are, just know that it all has to come together from just a functional standpoint. Can the person move well and without pain? With whatever it is that you're measuring. And again, the sneaky one in all that you mentioned, Tony, was knee extension with the hamstring. A lot of people don't look at what's happening at the knee to determine how well the foot and ankle is working or can work, because that could be the one sneaky point as far as, well, why isn't this person improving, right? Mm-hmm. Or why does this person keep getting injured at the foot and ankle? Well, did you ever look at the knee? As far as what information that can provide to you, as far as which muscles that need some, a different integrative approach when it comes to the strengthening aspect.
Yeah, for sure. Cool. Trying to think here. Want to be mindful of our time. When it comes down to kind of assessing progress, that's where your testing can come in. So you can do functional testing. We talked about range of motion. Specific to the foot and ankle, you can do things like the BEST test, balance error scoring system. You've got star excursion balance test, which is basically, a single leg balance with a reach of the opposite leg in different planes. You've got your transitional movement assessments, which Ken, you mentioned, single leg squat in particular. You could also do a lateral step down test where you're looking at kinetic, the alignment of the lower extremity and kinetic chain checkpoints. And then as you progress into more dynamic activities, you've got things like a shark skill test, which is probably more specific to NASM than anywhere else. I haven't really seen that assessment in too many places, but that's a great assessment to assess lower extremity agility, reactive control, and alignment. And it provides you some objective data to compare the affected side with the non-affected side.
Right.
And then there's a variety of other tests that you could throw in there too, based on the sport, and what that full recovery looks like.
Right. And I'll say that.
Go ahead.
Oh, just with the shark skill test, that's been one that I've used on different levels. So for those of you that don't know what a shark skill test is, basically it's a 3x3 grid, so 9 boxes, and the way it's performed is it's a single leg hop, going, if you figure the boxes are numbered 1, 2, 3 across the top, 4, 5, 6 across the middle, with the number 5 being the center box, and then 7, 8, and 9, you're just timing how fast it would take you to finish a single leg hop from, let's say, top left back to center, forward back to center, until you've finished all the boxes, and then land back on the middle box. So as we've performed it, and great agility assessment, looking at, okay, well, going back into the left, I see that you're a little sticky there compared to going forward and to the right. And, just pick a leg, so you can look at it quantitatively just from a timing standpoint, but also qualitatively as far as which direction you may show a falter. And again, out of those that you listed, all great, but the shark skill winds up being my go-to from that standpoint, because I'm looking at you from multiple directions. But the other thing is that it can be scaled, right? So I've taken, a client, that same client that's 65 years old in my head, I can have them walk, so take a, left foot, have 2 feet in each box, and I can look at, their ability to confidently go, forward, lateral, backward, lateral, in those directions. So taking that, what we could do as a single leg hop to a 2-leg, jump, back and forth, or even scaled back even further into a walking pace for those that, they're not looking for, elevated high speed single leg work, but just the fact that some people just going backwards at any direction, right, may be an issue, right? So if someone's playing, if it's a senior softball league, can they run backwards if there's a pop up over their head? Those are the things that, you want to look at, as far as building up their confidence, or using assessment to look at their confidence and going in different directions. So all great assessments, all practical, but the shark skill, I'll say, is the most robust as far as what it offers you in the information that you can use to create a program.
Yeah, fantastic. I love it. Yeah. Great stuff. Cool. Well, I think before we get into some of the specific strategies, the last thing, and I know we've highlighted this, is ultimately the goal is to reestablish and build upon reactive neuromuscular control and dynamic stability. And so when we get into some of the exercises, it'll be important to leverage the principle of overload, progressive overload, and darn screensaver again. Sorry, gang. And you want to be progressive in your programming. And so, just some key things to keep in mind. We'll probably echo this in subsequent episodes. And, movement complexity demand. You want to make sure that you're, starting with simple exercises and then progressing to more complex patterns. Proprioceptive demand, more stable environment to a less stable environment. Predictability. So, doing things that the athlete knows what to expect into a less predictable environment. Speed of movement demand, slower speeds to progressively faster speeds. Planes of motion, sagittal plane, frontal, transverse plane. Most individuals are going to have the most control in the sagittal plane, followed by frontal plane, followed by transverse plane. So you have to make sure you address all that. And then the muscle action spectrum, eccentric, isometric, and concentric. And that's one of the great things about the corrective exercise continuum, which is going to be a key component here, is that the exercises in the activation step and integration step are done at slower tempos, where the focus is largely on the eccentric and isometric elements of the pattern. And those are going to be really, really important and beneficial to a lot of these conditions or injuries that you might encounter, particularly at the foot and ankle, but also as we get into other parts of the body. So, focusing on eccentric stimulus to the tissues, the ability to isometrically stabilize in different positions and at different tissue lengths is going to be really beneficial, and has been shown to be very impactful when it comes to coming back from some of these things. And then we talked about this as well, client psychology and confidence in their ability to do these exercises that you're asking them to do.
Right.
You have to make sure that you reaffirm that they're good. Everything that you see indicates that they should be able to complete the exercise that you're asking them without cause for concern, and just be able to reinforce that to build them up and aid in that process along the way.
Right. And getting back to your progressions, and one of the things that helps make your job easier as a rehab coordinator or rehabilitation specialist or personal trainer is if you take out a sheet, and if I look at something as simple as just a single leg balance, you can draw out 4 weeks worth of programming. And this is what coaches love. And if you want more referrals from a medical professional, physical therapists, doctors, they'd love to send people, especially injured clients or patients, to fitness professionals. It's just they don't know anybody, and the ones that they do know, they may or may not have had a good experience. So one of the ways you build a case for building up that referral vantage point is come up with a plan, right? So if you have that single leg squat, so maybe week 1, single leg squat, with a forward and backward reach, single leg squat, this is day 2, single leg squat with a lateral reach, single leg squat with a rotation in the transverse plane. And then maybe week 2, it's a single leg squat with the lacrosse stick or whatever implement. It could be a tennis racket, whatever it is that they're having. So a single leg squat with the racket in their hand, or a single leg squat with a little torso rotation to the opposite side. So then you can segment the movement. So it's single leg squat, and then once they stand up, add the rotation. And then week 3 is now you have the single leg squat with rotation, right? So then you can progressively create this plan, whether or not you do it or not, or you get to that point where it's appropriate, because some people may be like, this is too easy. Well, at least you have, okay, here's the next step. We're a week ahead of schedule. But again, part of keeping the athlete engaged in this whole, return to performance phase is, you got to keep them stimulated. And again, whatever they're doing has to look and smell like the sport that they're playing. So again, working on foot and ankle dynamics with, the squatting motion, putting a football in their hand, a tennis racket, a baseball, a bat in their hand. If you can some way figure out how to integrate their activity back into this process, it makes it feel less like corrective exercise and more like the sport that they're playing in. So again, progressive programming does require a little bit of creativity, and that's just going to be based on your conversations with the athlete, but also, the imagination that you have to bring to the table.
Yeah, no, fantastic. Love it. And, that also shows the athlete that you have a plan for them, that you care about where they end up, and you care about what happens to them in this process. I think,
right.
I've had a number of clients who have worked with a variety of different professionals, and you'd be amazed. Maybe you wouldn't. Maybe it shouldn't be as much of a surprise as it is at the collegiate or professional level, where there was no plan in place. And
right.
To the athlete, that doesn't instill a lot of confidence in the individuals that are helping them. So whether you stick 100% to that plan or not is beside the point. The fact that you've taken the time to lay that out, you've given some thought to it. You've reviewed that with the athlete, asked for their input, tried to, incorporate things that would enhance
Mm-hmm.
their engagement and buy-in, that speaks volumes to the athlete,
Right.
and they're more likely to buy in when you do that.
Yeah, and I've had personal experience where they've gone back for their reevaluation with their respective physical therapist or even their surgeon, and if they go there and they're like, yeah, these sessions, I'm feeling good, I'm feeling strong, they just it's that glimmer in their eyes, it's that the fact that they're excited about the process, and whatever you can do to facilitate that through your programming, again, as creative as it can be. You have to do it, because then once that physical therapist sees that you're planned out and you've thought about it, you've been considerate of the whole situation. But, for two is that, you know what session 1, 2, and 3 of week 1, session 1, 2, and 3 of week 2, you know what that looks like. And the fact that you're communicating that and getting that information out there with the athlete, as well as with the medical professional, that's going to be how you build your business. If this is where you want to create your niche when it comes to client management.
Yeah, no doubt. Great points. So with that, Ken, let's kind of finish up, I guess. We've talked about a lot of stuff. But we have yet to talk about the actual strategies and programming specifically. Oh, man. Yeah. So when it comes to the actual programming in this sense, we are going to leverage the NASM Corrective Exercise Continuum for our framework, where, for those of you who aren't entirely familiar, maybe not familiar at all, the Corrective Exercise Continuum is a 4-step process that consists of, the first step being inhibit, and we're going to utilize different techniques and tools to relax or decrease overactivity in certain tissues that and muscles that may contribute to a faulty movement pattern. The second step is what we call lengthen, where you're going to incorporate stretching techniques or flexibility techniques that enhance the extensibility of the target muscles. So the goal with these first 2 steps is to restore or enhance available range of motion. And that's going to set you up for greater success in the next 2 steps, which are activation. So once you've improved or enhanced the ability for the joint to move through range of motion, then you want to retrain or develop greater muscular control through that range of motion. So activation is going to be done on muscles that have been identified as being relatively underactive, that might be allowing a particular faulty movement to take place. So you're going to do specific exercises and techniques to re-engage those tissues. And you're going to work those through that new range of motion that you've attained from the previous 2 steps with the flexibility techniques. So inhibit, lengthen, activate, or strengthen, if you will. Inhibit, lengthen, strengthen. And then the final step is what we call integration, where you've restored range of motion locally to select joints. You've developed isolated strength around those joints and control through those specific ranges of motion. Now we want to integrate that into a more functional pattern, more functional body position, where the joints that you just impacted locally have to work in coordination with the joints above and below it, and in a variety of different environments. And so that integration step is extremely important. And then with maybe as a subsidiary or kind of another component to the integration step is, making sure that whatever you do from an integration standpoint is progressive and kind of replicates from a performance perspective what they have to do on the court or in the sport that they're trying to return to. So that may be specific drills where you're challenging speed, agility, quickness, and other attributes to get the body to respond and perform in an environment that's specific to that person's activity. Did I explain that okay, Ken?
You explained it more than okay. And this is the thing about when you're working with somebody from a, I guess, a reintegration into sport standpoint, is that it's, first of all, you got to get them out of the mindset of sports specific training. We get a human specific training. So we have to look at human movement science. And, this is what, helps facilitate better movement, and not just at the site of injury. In this case, it's the foot and ankle, but also how the whole body, how we reteach the body how to use this new, updated, upgraded, area, which is, again, we go from a position of compromise to enhanced movement. So even, and you've seen it, Tony, you get 4 degrees better ankle dorsiflexion on somebody. Sometimes that's enough to make, man, that feels awesome, right? Mm-hmm. So now you have to teach that. And I guess this is the other part, is that, the reason why there's 4 steps, right? Inhibit, lengthen, strengthen, and integrate, is because it takes all 4 steps to work together to keep what you work for. So when you talk about optimized, range of motion, can we get the muscle, that the local area, to relax enough that we can get some length, and then we have to reteach and strengthen it up, to use that new range of motion. So, and this is the number one thing when it comes to the whole recovery strategy is, can you keep it? Because how many times have you heard, it's like, I stretch and I stretch and I foam roll, but I still get tight, or I'm still getting this little pinch or whatever. It's like, well, did you do everything I told you? And when I say everything I told you, I meant all 4 steps. It's like, no, I just had time to foam roll. And I foam rolled my whole body. Well, instead of foam rolling your whole body, why don't you take a quarter of that time to foam roll, and then spend the other 3/4 of that time to get a little bit of a stretch, get some strengthening in there, and then a single leg something to put it all together. That's the importance of having all 4 steps put together, because it's not just about flexibility. Flexibility in and of itself is nothing. If anything, it puts you in harm's way more, because you've got all this range of motion that your brain does not know how to control, right?
Yeah,
and
exactly.
The rest, every other player on the team doesn't know how to play with you. That's the big part of it. So putting it all in one lump sum, as far as that goes, is the biggest teach when it comes to this kind of sideline type of training. Yep.
Absolutely. So let's talk through those 4 steps a little bit. From an inhibitory standpoint, what are the areas that we would want to focus on with an athlete coming back from a foot and ankle situation?
Yeah, the biggest thing, I mean, when you look at all the areas that we, all the muscles that you talked about, and the biggest part is the calf complex, because of what it can do to affect the knee above it, but also how it connects into the calcaneus, and then how that extends down into the plantar fascia. So there's a lot to be said for what's happening behind the leg, as far as it affects what's going on, below it at the ankle and the foot. So the calf is one of the bigger parts to hit. But, when we talked about plantar fasciitis, that we talked about an hour ago, helping offset some of the tension down there.
Don't remind them how long we've been on here, Ken.
If you're still here with us, you're
might have to break this one into 2 parts.
Part 2. But from that standpoint, I mean, just getting the inhibitory process going, and again, when we talk about tools, one of the footnotes I've kind of jotted down here, between the foam roller, you have old school, lacrosse ball, golf ball, but with technology as it's been these last few years now, when you talk about vibration, percussion, implemented into your tool, I mean, my clients have definitely made the investments in themselves as far as how do you maximize the inhibitory process and getting the muscles to relax. So, getting the right tool for the right job to get the muscles to relax is going to be one of the things that they're going to have to spend some time on. But the back of the leg, bottom of the foot, for the most part. But whatever feels good. When let's say if you get the hypervolt out, boom, get that on there, get that area to relax.
Yep, no doubt. So inhibit calf complex, maybe focus quite a bit on the lateral aspect of the gastroc.
Very much, yeah.
Soleus, biceps femoris, as we talked about, even though it affects the knee joint mechanics, that's also going to affect the foot and ankle mechanics by way of the fibula. Rolling the plantar fascia, I'm glad you mentioned it, lacrosse ball or, some other type of firm ball. With respect to the plantar fascia, that's an area that people tend to go really aggressive with.
Right.
That may not be ideal. You don't necessarily have to go super aggressive. You can certainly focus on areas of discomfort and tenderness, but you don't need a ton of pressure into that region in order to experience some great outcomes. Oftentimes, just getting fluid moving through that tissue is going to be really impactful, and that's where vibration and percussion and some of the newer tools can really be beneficial. And then depending on the specific scenario, focusing on the fibularis muscles or peroneal muscles on the lateral aspect of the lower leg may be warranted too, from an inhibitory standpoint.
Right.
Cool. From a lengthening standpoint, basically we would kind of focus on the same areas, right? Is that?
Yeah, and so when you talk about the lateral gastroc soleus complex, the one thing that I'll say there again, we can list out a bunch of stretches. We can, do a stretch for the short head of the biceps femoris, working on that lateral hamstring as it affects like everything that you're saying with how the fibula interacts with the foot and ankle. But what I want to say with the lateral gastroc soleus complex, it's basically the lateral calf stretch, is that position is going to play a big part of how you emphasize the stretch in this case. So doing the best you can to maintain subtalar neutral, a little bit of internal rotation, activation of the hips, getting that little posterior little squeeze in the glutes, squeeze in the quads, making sure that the knee is extended, the hip is extended, and that the heel is on the ground. Because the one thing about that stretch, as much benefit as that stretch is going to give you, if it's not performed correctly, you're not going to maximize it. If anything, you're going to reinforce the compensation that goes along with that particular stretch. So to tap on a couple times the importance of the lateral gastroc soleus, with multiple compensation patterns. The technique is what's going to be the important part of that.
Yeah, no, great points. And I guess I don't know if I mentioned this or if we specified this, but typically in this second step for the lengthening strategy, we're going to utilize static flexibility techniques.
Yes.
If you're doing something with the client, you could certainly do a partner assisted stretching technique like a neuromuscular stretch or, PNF stretching. But for the athlete or the client, for their homework or their self-led program, they're going to be doing a static stretching technique.
Right. Yep. And if you're again, personal trainer, again, unless you have the licensure or the education and the training to put your hands on somebody, don't do it, because it just takes that one time for something to go wrong that you can find yourself doing something else for a career. But from the other standpoint, when we talk about homework, when it comes to athletes, I take a very hands-off approach. Despite my background, because if I'm doing it for them, I decrease the opportunity for them to learn to do it for themselves. So verbal cueing, visual cueing, whatever I need to do to get them to be able to do this and execute on their own. Any opportunity you have to do that, because they're not going to have your eyes on them, every time that you want them to do it, which is, before and after a workout, maybe after they've been sitting behind a desk or after a long drive, things like that. So, or if they're on the sideline during practice, if they can take these opportunities to perform these static stretches from a corrective standpoint, find the opportunities to teach them to do these stretches or exercises on their own with good form.
Yeah, for sure. So, nice segue there into exercises. So that third step, the strengthen step, or in the CES continuum or corrective exercise continuum, it's referred to as activate, where you use isolated strengthening techniques. What would we want to focus on in that particular aspect of the program?
Oh, this is the hardest part for a lot of athletes to do, because this one, it's a long time, low intensity, usually body weight, but long time under tension. So when we talk about tempo, especially from a corrective exercise standpoint, it's going to be something along the lines of 4-2-2, 3-2-1, with that first number being the eccentric, second number being isometric, and then that third number being the concentric. So if it's a 4-2-2 tempo, something that's very slow on the eccentric, and you're, seemingly a long time for the isometric, because you have to hold that shortened position for a couple seconds, right? But let's say if it's a single leg calf raise, or just calf raise with a slight internal rotation of the feet to emphasize the strengthening of the medial fibers of the gastroc. So that's, you're standing up, extending up, pushing the toes into the ground. Again, trying to do the best you can to keep more of a neutral position at the ankle. So you're going to come up, hold for a couple seconds, and then you're going to slowly lower yourself to the ground. So again, most injuries do happen in the lengthening or the eccentric phase. So that's where we need to, build up strength and stamina, is in that eccentric portion of that contraction spectrum. So slow, time under tension, with special emphasis on the lengthening of that particular muscle. So the one muscle or the one exercise that I'm picking for this is that calf raise, with emphasis on the medial fibers of the gastroc. So up, hold, and then super duper slow on the way down.
Yeah. And you mentioned eccentric, isometric, concentric. Typically that isometric contraction is performed in the shortened range of motion, but you could also do it in the lengthened position as well as that client progresses. So in the case of the calf raise, you could have them hold in the shortened position when they're up on their toes. And then as they slowly lower back down to the start, you could also have them hold in the eccentrically loaded position as well. And that could provide some great stimulus and stress through this process. So you could have them do one or the other, progress from that shortened position to the lengthen, or you could do both, I guess, right? You could have them hold it at both positions.
Right.
They'll really love you then.
Keep them wanting more.
Yeah. Cool. So single leg calf raise with toes turned in. What other areas do we want to address? Would you do like anterior tibialis potentially? To reinforce that range of motion and control through dorsiflexion and inversion. That single leg calf raise with toes in, emphasizing the medial fibers of the gastroc. That's going to reinforce inversion of the foot as well. And then what else? How about up at the hip?
The glute. I mean, that's because again, when we talk about, again, from an athletic endeavor, talk about triple flexion, and we have to talk about triple extension. So again, when it comes to pushing off, changing direction, if the knee's extended, foot's plantar flex, and you're extended at the hip. So when it's going to be short and it's most when you're trying to drive that power, it's going to come from the hip. So and that's where, again, going back to that calf raise, getting that triple extension. So if they're holding onto a bar and they're elevating themselves, pushing those toes into the ground, not only are they plantar flexing, but they're also extending, getting that hip extension in there. So, basic glute exercises as well. Again, we'll talk about that at the next, well, when we discuss the hip, but again,
and the knee, right?
Yeah, and the knee, and the shoulder.
Yeah. Glutes.
Yeah.
Love the glutes.
Yeah, the glutes. You can't keep that out of the conversation, any conversation, really. Yeah.
So, proximal stability, looking at glutes. Remember, many of the things that we talked about stem from the inability to decelerate over pronation. And so the glutes and the muscles of the hip are going to be key players in that. So making sure the glute medius and glute max are getting some love is going to be important. And you can certainly do isolated work for that, whether that's, side lying leg raises, mini band exercises, hip extension, quadruped stuff. I mean, the sky's the limit.
Yeah, exactly.
You alluded to this earlier just by talking about talking through the exercise, but the focus on, precision execution is going to be key with these activation and strengthening exercises. So have the client do whatever they can through any range of motion, full available range of motion without compensation or pain and discomfort.
Right.
And then in the case of the foot and ankle, what are some integration and performance type drills that you would follow up with once we've done our activation and strengthening?
Yeah, I like to do things like, single leg work, single leg marches, to where if I'm standing on one leg, I've got them, in like a sprint pose. So if I'm standing on my right leg and my left knee is up, I'm going to have my right hand up, just like if they were driving and they're that left foot, you're ready to hit the ground. And I'll just have them stand on that right foot, and then they'll just tap the foot on the ground, and then they'll come right back up again. So all the while they're balancing on that right leg, but I'll integrate that little step and balance, right? Hold for a couple seconds, step and balance. So what has to happen with that right leg, essentially, and that right foot and ankle, it has to control that shift, that change in the center of gravity. Plus now you're integrating a shoulder swing into the mix. So again, just to take it a little bit farther than where I would take just a regular, somebody that doesn't have, a sports performance goal, to where I might just have them stand on a single leg and, do a little reach. Here, I'm just going to be more progressive and adding an upper body motion. So if it's a runner, I'm going to have them start integrating, again, emphasizing a tall spine, good shoulder swing, right? And a quick tap of that foot and right back up. And then incorporating that coordination between the upper and the lower body. All the while, that right hip, right foot and ankle has to respond to everything else that's happening in the body.
Yep. Yeah. Fantastic.
Yeah.
Cool. Yeah, and you had mentioned some other exercises too, single leg balance with a reach. Also, any exercise for those of you who utilize the OPT model in your training programs with clients. Basically any upper body movement pattern while standing on a single leg can help drive forces through the lower extremity and into the foot and ankle complex. So think of this in terms of progression, and through the course of an entire training session, if you're trying to reinforce what happens at that foot and ankle complex, you can take that to every single exercise that you program, particularly if you have a client that's in that phase 1 stabilization endurance phase of training. So whether it's a chest press on one leg, If you're doing a core exercise, cable rotation, rowing patterns, lower extremity exercises, shoulder exercises, you can challenge that lower extremity during all of those. So
and one thing that I used to do, especially with football, because the powerlifting exercises are king, right? So to get somebody, let's say if I progress them to a strength endurance phase where you have a strength exercise supersetted with a stability exercise, they love their bench. They it's about what you can bench, right? So if I'm having somebody bench press and I superset that with a ball push up, just to keep, give them what they want, which is, okay, I need my upper body strength, but to sneak in a little bit of what they need, what they actually need, what they want versus what they need. I can have them in that ball push-up position. I can have them kind of rock back and get that little dorsiflexion and then creep into a little plantar flexion to where their shoulder is above the ball. They'll do that push-up, then they'll kind of rock back, and then they'll do their push-up. So it's, just adding a little pause. I mean, two benefits of that: a little bit more dynamic stability for their upper body, which is what they, what they need. But to sneak in that little reconditioning, I can get that little ankle movement while they're, again, dynamically stabilizing on that ball. So again, however you can sneak it in. Again, he thinks he's doing an upper body exercise. I know he's doing the upper body exercise, but I'm sneaking in that foot and ankle complex right along with it.
Oh, love it. Yeah. Cool. Well, anything else from a programming standpoint, performance drills that you would put in there?
Yeah, I mean, we can talk for another hour and a half on this, but
Greg's gonna love us.
Yeah, he is. But from the standpoint of, okay, what else can we sneak in there? Just add it. You take your traditional drills. You take your speed ladder. You can have a 4-cone drill, and instead of going run forward, lateral shuffle, backward shuffle, lateral shuffle to the left, add a pause or add a balance at the cones, right? Since you can shorten the distance. You go, instead of a 10-foot square with the cones, make it a 5-foot square. Increase the number of repetitions so that you can cover 2 laps, but you've integrated, instead of 4 stops, 4 cones, you decrease the position of the cones by half. You get the same distance, but you add twice as many stops. And it's the deceleration that's going to, the deceleration training that's going to help them learn how to stop and control. So instead of just going, go 50%, go 75%, go 100%, it kills me when I hear that. It's like, add in other things, stop, balance, hold for 2 seconds, and then transition. Stop, hold 2 seconds, and then transition. So you're sneaking in some balance work, some that isometric stabilization. And it doesn't have to be hard. You take what you already know, but just pause at different opportunities. You take that with a speed ladder. You go zigzags in and out. Pause. You're going lateral. Lateral in and out. So foot goes in the square. Balance on that outside foot. Transition back. Both feet are in the square. Balance for 2 seconds, and then come back the other way. And you do that over, 5 feet. Your athlete, if they're in that true reconditioning, they're going to be taxed. They're going to feel it. They're going to comment on how their foot feels, because it's traditionally something that they haven't done before. But that's what we're trying to build into them, is that strength and integrity that they were missing to begin with, that possibly contributed to how they got injured. So again, when it comes to return to performance, I want you to be stronger than you were before you got hurt, because it was that level of strength that allowed you to be in a position to incur more stress than what your body was able to handle.
Yeah. I love it. Great options. Takes a simple, multiplanar hop to stabilization to the next level, makes it a little bit more exciting and interactive, which is awesome. So cool. Well, gosh, I think that's enough.
Yeah, that's perfect. Yeah, just enough.
Yeah, I really enjoyed this, Ken.
Yeah, me
Looking
too.
forward to doing the rest of these. But thanks so much for all of you who listen, stayed on board for the whole thing. Hope you came away with some valuable nuggets and insights that you can integrate into your programming with clients, particularly around foot and ankle reconditioning. As mentioned at the top of the episode, if you have any specific questions, comments, feel free to leave them below, and we'll make sure to address them in our subsequent episodes. So with that, hope everyone stays safe, healthy, and takes care. Until next time, Ken, thanks so much, buddy.
Thank you, Tony.
All right. Talk to you guys soon. Bye.